Yes, so I welcome you all to this particular FMGE revision sessions. So today I will be discussing the clinical based questions on endocrinology. So in this particular sessions, we will be having a lengthy clinical based questions. Why? Because these are the one which are expected questions in your upcoming FMGE exams. So whenever you are solving these clinical based questions, you should have a thorough concentration whenever you are reading the questions. It is mainly due to lack of the concentration while reading a lengthy question that makes the question very difficult. So please ensure yourself that you need to keep utmost concentration while reading the lengthy questions. Otherwise, the question looks very difficult. But otherwise, the clinical based questions are very simple and very easy to crack the questions. Okay, right. With this, let me just start this particular session on the endocrinology today. Right, all the questions will be on the endocrinology, and that too, that will be clinical based questions. All right, now coming to the first question. Yes, Santosh, hi. Okay, so the first question is that we have a 75-year-old woman is diagnosed with hypothyroidism, and the individual is also having long-standing the coronary artery disease and is wondering about the potential consequence for her cardiovascular system. Which of the following statements is true regarding the interaction of hypothyroidism and the cardiovascular system? The options are: reduced stroke volume is found with hypothyroidism, blood flow is diverted towards the skin in hypothyroidism, myocardial contractility is increased with hypothyroidism, pericardial effusions are rare manifestations of hypothyroidism, reduced peripheral resistance is found in hypothyroidism and may be accompanied by hypotension. Right. So who will be the first person to answer this question? Right. Any one of you, please. So the question is correlating hypothyroidism and as well as the coronary artery disease. The question is correlating hypothyroidism and the coronary artery disease. Okay. Now let me tell you the answer. Yes, Sai Tarni, good evening. Very good. So Sandeep Chandra has answered it. Right? Sandeep Chandra and as well as Santosh has answered it. A reduced stroke volume is found with hypothyroidism. That is what is the correct statement, like what you will see in hypothyroidism and cardiovascular system. Now let me try to explain the mechanism. You need to understand, right? You need to understand what is the effect of T3, T4, that is thyroid hormone, on the cardiovascular system. Right? What is the effect of T3, T4 on the cardiovascular system? So T3, T4, what it will do is it has a positive inotropic effect. Right? It has a positive inotropic effect. And it also has the positive chronotropic effect. Right? And it also has the positive bathmotropic effect. Okay, now what does that mean? Positive inotropic effect, that means contractility. Thyroid hormone, it will increase the contractility of the myocardium. Right, it will increase the contractility of the myocardium. So in hypothyroidism, what will happen? In hypothyroidism, the contractility will be reduced. So when contractility is reduced, what will happen to the stroke volume? The stroke volume will be reduced. So when the stroke volume is reduced, what will happen to the cardiac output? Even the cardiac output is also decreased in these patients, in patients with the hypothyroidism. So that is what is the question. Hypothyroidism and coronary artery disease or the cardiovascular system, a reduced stroke volume is found in hypothyroidism is a true statement. The question asked is, what is the statement which is true? Now, the other point is, in patients with hypothyroidism, what you need to know is there will be decrease in the heart rate, right? There will be decrease in the heart rate. So they will have what is called bradycardia. Right, they will have what is called bradycardia. Okay, so thyroid hormone, they have positive chronotropic effect. That means they will increase the heart rate of the individual. In hypothyroidism, thyroid hormone is not there. So when thyroid hormone is not there, what will happen to your heart rate? It decreases. They will have bradycardia. Next, in these patients with hypothyroidism, they are also more prone for the pericardial effusion. Right, they are also more prone for pericardial effusion. Next, in these patients with the hypothyroidism, they can also have AV block. And in these patients with the hypothyroidism, they will also have diastolic hypertension. Why diastolic hypertension? Because thyroid hormone will decrease the peripheral resistance. If thyroid hormone is not there, what will happen? There will be increase in the peripheral resistance. So because of increase in the peripheral resistance, that makes the individual to land up in diastolic hypertension. Right? That makes the individual to develop what is called diastolic hypertension. Okay. Now, we will go back to the question now. So, blood flow is diverted towards the skin in hypothyroidism. Wrong statement. Blood flow is diverted away from the skin in hypothyroidism. Right? Blood flow is diverted away from the skin in hypothyroidism. Now, because the blood flow is diverted away from the skin, that is the reason why in patients with hypothyroidism, they will have cold intolerance. They will have cold intolerance. Why? Because the blood flow is diverted away from the skin. Next, myocardial contractility, it is not increased. In hypothyroidism, the myocardial contractility will be decreased. Right? Myocardial contractility will be decreased. Pericardial effusion is a rare manifestation. This is wrong statement. Right? This is wrong statement. Pericardial effusion is a very common manifestation of your hypothyroidism. Right? Next. Reduced peripheral resistance is found in hypothyroidism. No. If thyroid hormone is there, then it will reduce the peripheral resistance. But in hypothyroidism, what is happening? In hypothyroidism, the thyroid hormone is not there. So thereby what will happen to the peripheral resistance? The peripheral resistance is increased. So once the peripheral resistance is increased, they will not have hypotension. What they will have is hypertension. Right? What they will have is hypertension. So take home message from this question is that in patients with hypothyroidism, they will have reduced stroke volume. They will have reduced cardiac output. So that is what you need to know in patients with the hypothyroidism. All right. Next. Now, after having discussed about the hypothyroidism and as well as the cardiovascular manifestations, now let me take up one more clinical question. Yes. A patient has neurosurgery for a pituitary tumor, right? And he underwent the resection of the pituitary tumor, right? The pituitary tumor is there and he underwent the resection of the pituitary tumor. Which of the following functions of the adrenal gland will be preserved in this patient immediately post-operatively? First option, morning peak of plasma cortisol levels. release of cortisol in response to stress. Third option, sodium retention in response to hypovolemia. None of the above. Yeah. So yes, please, anyone? The individual has undergone the resection of the pituitary gland. Which of the following function of the adrenal gland will be preserved in this patient immediately post-operatively? Yes, so who will be the first person to answer this question? Right, very good, Dr. Bipin Kumar. So, sodium retention in response to hypovolemia, that will be preserved. Right, sodium retention in response to hypovolemia, that will be preserved. Okay, right. Why? I'll tell you. Now, you take the pituitary gland. What does the pituitary gland produce regarding the adrenal gland? Regarding the adrenal, the pituitary gland will produce the ACTH, adrenocorticotrophic hormone. Now, what does this particular adrenocorticotrophic hormone do? Adrenocorticotrophic hormone will stimulate, right? Adrenocorticotrophic hormone will stimulate the production of the steroids. Right, will stimulate the production of the steroids, and the adrenal gland, the ACTH, it will act on the adrenal gland. Now, adrenal gland will also produce the mineralocorticoids. Right, will also produce the mineralocorticoids. Okay, but remember, the production of the mineralocorticoids, is not under the influence of the ACTH. Right, it is not under the influence of the ACTH. Okay, the production of the mineralocorticoids, they are under the influence of RAS mechanism. Right, the production of the mineralocorticoids, they are under the influence of the RAS mechanism, that is renin-angiotensin-aldosterone system. So even though you do pituitary gland resection, right, if you do a pituitary gland resection, the steroid production does not occur, but mineralocorticoid production is not affected. Right, mineralocorticoid production is not affected at all. Okay, so now you see here, morning peak of the plasma cortisol levels, they are affected, they will be reduced. Release of the cortisol in response to stress, that will be affected. So cortisol levels will be reduced. Right, cortisol levels will be reduced. And sodium retention in response to your hypovolemia is not affected. Why? Because mineralocorticoids are present. What does the mineralocorticoids do? Mineralocorticoids, they will cause sodium and water retention. Right, they will cause the sodium and as well as water retention. Now, because mineralocorticoids, they will cause sodium and as well as water retention, so sodium retention in response to hypovolemia, it is preserved. Right, it is preserved, but your morning peak of the plasma cortisol, not preserved. Release of cortisol in response to stress, not preserved, because both of them, they are under the influence of your ACTH. Now, whenever the pituitary gland is resected because of the pituitary tumor, the ACTH levels are reduced. When your ACTH levels are reduced, your cortisol release is being reduced. Right? Cortisol release is also being reduced. So that is the reason why the answer is sodium retention in response to hypovolemia is not being affected. Now, even you take in case of the adrenocortical insufficiency, like for example, you take in Addison's. What is Addison's? It is primary adrenocortical insufficiency. It is primary adrenocortical insufficiency. Now, what do you mean by the word primary? Right? What do you mean by the word primary? The word primary means the pathology is directly within the gland. Right? The word primary means the pathology is directly within the gland. In this case, your corticosteroids are reduced. Mineralocorticoids are reduced. And weak sex hormones are also reduced. Right? Weak sex hormones, they are also reduced. Whereas we have another terminology called secondary adrenocortical insufficiency. In secondary adrenocortical insufficiency, right, in secondary adrenocortical insufficiency, where there is a decrease in ACTH only, here there will be decrease in only steroids. Right, there will be decrease only in steroids. In secondary adrenocortical insufficiency, aldosterone, that is mineralocorticoid levels, are normal. Right, aldosterone, that is mineralocorticoid levels, are normal. They are not being affected in secondary adrenocortical insufficiency. Why? Because mineralocorticoids, they are under the influence of renin-angiotensin aldosterone system. They are not under the influence of your ACTH, right? So now remember this point. The individual undergoes pituitary resection. Sodium retention in response to hypovolemia is not affected. Right? Sodium retention in response to hypovolemia is not affected. Okay, right. Now we will move on to the next question. Yes, question looks very lengthy, but you need to solve these type of questions, and these are the type of questions which are expected in your exam also, right? Please don't get scared by seeing the length of the question. You try to understand the question, try to apply the concept. Definitely you can crack the question. Okay, right. Yeah, Mr. McTrapp is admitted to the hospital after a car accident, right? So he had a road traffic accident. His medical history is unknown, right? His medical history is unknown, but he made a car accident. And on presentation, he is obtended and can provide no history, right? He is completely obtended and he is not in a position to provide any history at all. And the CT scan revealed the splenic laceration. The spleen is cut off, lacerated, and he is emergently taken to the operating room for splenectomy. Right? He undergone splenectomy without any complication. At the completion of the operation, all the bleeding has stopped and he returns to the intensive care unit. However, he remains deeply hypotensive with a blood pressure of 70 mercury, with an increase in 82/52 with a bolus of 2 liters of normal saline. He is afebrile with normal WBC count. Repeat CT of the chest, abdomen, pelvis shows no hemorrhage. Right? CT chest, CT abdomen, CT pelvis shows no hemorrhage. Jugular venous pressure is not visible above the clavicle. Right? Jugular venous pressure is not visible above the clavicle. He has round face and is obese, and you note the following on physical examination. He has no hand hyperpigmentation as well. What is the next most appropriate step? Return to the operating room for exploratory laparotomy, administer hydrocortisone, administer vancomycin and piperacillin plus desobactam, insert intra-aortic balloon pump for counterpulsation, perform MRI of the spine. Yes, any one of you please. What is the diagnosis and what is that you need to give in this patient? What is the diagnosis? What you want to give? What you want to administer to this particular patient? What is the worrying thing? We are very much worried about the hypotension. Okay, VS says B, administer hydrocortisone. Why VS? Why you want to give? Why you want to give hydrocortisone? What are you expecting? What is the diagnosis? So now let me tell you the diagnosis. Now Cushing's. So if it is like Cushing's, why do you want to give hydrocortisone VS? Cushing's is what? Cushing's is a condition which is characterized by increase in your corticosteroid levels. Already corticosteroids are very high in Cushing's, but then upon that, why do you want to administer hydrocortisone then? Yes, even Santosh also answered administer hydrocortisone. Why Santosh? Why do you want to give hydrocortisone in this patient? What is your diagnosis? Right. Now let me tell you the diagnosis. See, this particular patient is having, the answer is B. Whatever you people were telling is correct. Administer hydrocortisone is a correct statement. But what is the diagnosis? Let me tell you. So this particular patient is suffering with acute adrenal insufficiency. Right? This patient is suffering with acute adrenal insufficiency. How, sir? Why do you tell that? I will tell you. Why? Because what are the triggers for acute adrenal insufficiency? The triggers for acute adrenal insufficiency is number one, trauma. Number two, infections. Right? So one is trauma and the second one is infection. These are the triggers for acute adrenal insufficiency. Our patient had a road traffic accident. Right? Our patient had a road traffic accident. That is trauma. Right? That is trauma. So whenever there is acute adrenal insufficiency, what is the drug of choice? The drug of choice is hydrocortisone. Now this particular hydrocortisone, why sir? Why hydrocortisone should be given? Right? Why hydrocortisone should be given? Why? Because hydrocortisone, it has the dual activity. What is the dual activity? It has the mineralocorticoid activity and corticosteroid activity. Right? And it also has the corticosteroid activity. So both of these, they will increase the blood pressure of the individual. Right? So both of these, they will increase the blood pressure of the individual. So that is the reason why you give hydrocortisone to the patient. Now, infection, right? What is that infectious organism that can cause acute adrenal crisis? The infection that can cause is Neisseria meningitidis. And that is in children. Right? That is in children. And what is this called? Waterhouse-Friderichsen syndrome. Right? Waterhouse-Friderichsen syndrome. Okay, so that is what is the acute adrenal crisis causing infection, caused by infection. Okay, now the point is, sir, why did you opt for B? Why not others? Right? Why not others? Why did you go with the B? I will rule out one by one. I will rule out one by one for you. Okay. Now, what does the CT scan shows? The repeat CT? Repeat CT scan of the chest, abdomen, pelvis shows no hemorrhage. Shows no hemorrhage. So Return to operating room for exploratory laparotomy. Please don't do that. Not required, because CT is showing no hemorrhage. Why do you want to do exploratory laparotomy again? Okay, next. Now, the other point is, you take the WBC count, right? WBC count is done. The individual is having normal WBC count. So, that means what? Sepsis is ruled out. Right? Sepsis is ruled out. So, when sepsis is ruled out, why do you want to give antibiotics? Vancomycin and piperacillin tazobactam is not required in this patient. So your C is ruled out. Okay. Then now you take the IABP. IABP, intra-aortic balloon pump. It is indicated in cardiogenic shock. Right? Cardiogenic shock. Secondary to heart failure. Right, secondary to heart failure. Okay, so in this patient, if you see, the jugular venous pressure is not visible. Right, jugular venous pressure is not visible above the clavicle. So when jugular venous pressure is not visible above the clavicle, it is not your heart failure. Right, the individual is not in a state of heart failure. So please don't do insertion of the intra-aortic balloon pump. Right, then what is that you are suspecting? There is a trauma that has induced acute adrenal insufficiency that makes the individual to get treated with hydrocortisone. So the answer to this particular question is hydrocortisone. Okay, right? Performing the MRI of the spine, what is the use? It is of no use. Why you want to do MRI of the spine? Right? Many of you are answering E. Selvaraju, Bipin Kumar, right? You are answering E. Why you want to perform the MRI of the spine? What is your suspicion? But definitely, yes, patient is having Cushing's. Round face is there, obese individual, presence of the purple striae. This patient is having Cushing's. I am not denying that. Right? I am not denying that. Under the history of Cushing's, he has developed acute adrenal crisis secondary to trauma. That is the reason why I want to administer hydrocortisone. Right? So I hope everyone has understood this question. Yes, just tell me yes or no, or just give me a thumbs up so that I'll be happy that you have understood. It's a thought damage to the cardiac fibers. Okay. Oh, no. Don't think up to that level. Right. Okay. Now we will move ahead with the next question. Right. Next clinical based questions we will take up. Yes. This is another very interesting question. We have a 54-year-old woman with long-standing hypothyroidism is seen in her primary care physician's office for a routine evaluation. She reports feeling fatigued and somewhat constipated as well. Since her last visit, her other medical conditions, which include hypercholesterolemia and systemic hypertension, have been stable. She was diagnosed with uterine fibroids and started on iron recently. Her other medications include levothyroxine, atorvastatin, and hydrochlorothiazide. A TSH is checked and it is elevated to 15 milliunits per liter. Which of the following is the most likely reason for her elevated TSH? Celiac disease, colon cancer, medication non-compliance, poor absorption of levothyroxine due to ferrous sulfate, TSH secreting pituitary adenoma. Which of the following is the most likely reason for her elevated TSH? Right. Yes, anyone want to make an attempt of this question? So the individual is hypothyroid. The patient is on levothyroxine, but the TSH is still 15 milliunits per liter. Which of the following is the most likely reason for her elevated TSH? Medication non-compliance. That is what Tenso has answered. Bipin Kumar has answered poor absorption of levothyroxine due to ferrous sulfate. Very good Bipin Kumar, very good Sandhya. The answer is D. The answer is D. Now let me tell you. Okay. Now let me tell you, in a patient with hypothyroidism, taking levothyroxine, but still the TSH is elevated, what would be the reasons? Okay, patient with hypothyroidism. The patient is on levothyroxine. Right, the patient is on levothyroxine, but still the TSH is elevated. The still TSH is elevated. Now, what all could be the reasons? Right, what all could be the reasons? Number one, it could be because of non-compliance. Non-compliance to medication. Okay. Number two, poor absorption of the thyroxine. Right, poor absorption of thyroxine from the GIT. Number three, drug-drug interaction increasing the clearance of the drug. Right, drug-drug interaction increasing the clearance of the drug. Right, increasing the clearance of the drug. Okay, now when will you expect the non-compliance? Right, when will you expect the non-compliance? When will you expect the non-compliance is when, right, the patient is taking levothyroxine 200 micrograms. The patient is taking levothyroxine 200 micrograms, but still if the TSH is elevated, then you consider non-compliance. Then you need to consider non-compliance. But here, the dosage of levothyroxine, how much the patient is taking, is not given. So we don't consider. And as Bipin Kumar is telling, right, so already the individual is taking many other medications. So why do you expect to have the non-compliance? It is very less likely. Okay. Next, poor absorption. Right. Now, gastrointestinal disorders like celiac disease, right, celiac disease, right, and the other thing, that is small bowel surgery, right, small bowel surgery. So these are the conditions which will cause the poor absorption of the levothyroxine. And not only that, right, not only that, even your ferrous sulfate, our patient is taking iron supplementation. Ferrous sulfate, this will also decrease levothyroxine absorption. Right, this will also reduce levothyroxine absorption across the gastrointestinal tract. Right, across the gastrointestinal tract. Right, next. See, yes, Bipin Kumar, what I am trying to tell you is, when the patient is taking more than 200 micrograms, definitely the TSH should be reduced. But in spite of taking more than 200 micrograms, If the TSH is still elevated, that is the point when you have to suspect the non-compliance to medication. That is the point when you need to suspect non-compliance. That is the point telling that the individual is having non-compliance, right? Okay. Now coming to the, yes. Now celiac disease. Celiac disease is there in our option, but there are no other features of the celiac disease. Right? There are no other features of the celiac disease like weight loss and all is not mentioned in this. Okay, so your celiac disease is ruled out. Okay, next, yeah, next, poor absorption of levothyroxine due to ferrous sulfate. That is a correct statement, right? And not only that, even some drugs, there are some drug-drug interaction that will increase the clearance of levothyroxine. So what are those drugs which will increase the clearance of the levothyroxine? Number 1, lovastatin. Number 2, amiodarone. Number 3, carbamazepine. Number 4, phenytoin. So these are the drugs which will increase the clearance and will decrease the levothyroxine levels. Right, and will decrease the levothyroxine levels. Okay, so the answer to this particular, now, but what our patient is taking, our patient is not taking lovastatin. Our patient for hypercholesterolemia, he is taking atorvastatin. Atorvastatin will not increase the clearance of the levothyroxine. So we are not worried about the atorvastatin. What are we very much worried about? The patient has started taking iron recently. This particular iron, that is ferrous sulfate, that is the one which will reduce the gastrointestinal absorption, right? So the answer here is poor absorption of levothyroxine due to ferrous sulfate. So in a patient with hypothyroidism, whenever you are giving levothyroxine supplementation, you need to look for all these parameters, whether the individual is compliant to the medication or not, whether is there any factor which will reduce the absorption of levothyroxine. Then you need to see any other drugs which the patient is taking will interact with the levothyroxine, like lovastatin, amiodarone, right, and carbamazepine and phenytoin. So these are the drugs which will increase the clearance. These are the drugs which will increase the clearance. All right. So poor absorption of levothyroxine due to ferrous sulfate is a correct statement. Okay. Now we will move on to the next question. Yes. Now, if this is the next important clinical based question. Even you see here, the question looks very lengthy, and even you see options, they are also very scary, right? But you should not get frightened by seeing these type of questions in your upcoming FMGE exams. So our main motto is to see that you should get very much familiarized by seeing these type of questions. Okay, right? Because your single liner questions and all, they are completely outdated, right? They are not asking now. They may or they may not ask you single liner, but definitely clinical based questions are the one which will decide whether you will be able to get 150 or not. So please get exposed to as many as the clinical based questions rather than the single liner questions. Okay. Now we have a 87-year-old woman admitted to the intensive care unit with depression, with depressed loss of consciousness, depressed level of consciousness. And the individual is also having hypothermia, sinus bradycardia, hypotension, and hypoglycemia. She was previously healthy with the exception of hypothyroidism. So hypothyroidism was there in the past. And systemic hypertension also was there in the past. Her family recently checked in on and found that she was not taking any of her medication. For hypothyroidism, she should be given levothyroxine. But the patient is not taking her medication because of the financial difficulties. There is no evidence of infection on examination of the urine or chest radiograph. Her serum chemistries are notable for mild hyponatremia. Right, for mild hyponatremia, and glucose of 48 milligrams per deciliter. TSH is elevated more than 100 milliunits per liter. That means what? Patient is hypothyroid. The patient should take levothyroxine. When the patient takes levothyroxine, then the TSH levels will be reduced. But the patient is not taking levothyroxine because of the financial difficulties. So the TSH will touch the sky. All of the following statements regarding the condition are true except external warming is a critical feature of therapy in patients with temperature less than 34 degrees centigrade. Hypotonic intravenous solution should be avoided. Intravenous levothyroxine should be administered with IV glucocorticoids. Sedation should be avoided if possible. Fifth option, this condition occurs almost exclusively in the elderly and often is precipitated by an unrelated medical illness. Okay, Rakshit Narayan has already answered. He says sedation should be avoided if possible. Okay, any other answer? What is the diagnosis, first of all? Who will tell me the diagnosis? What is this patient suffering with? Yes? What is this patient suffering with? Any one of you? Right. So this particular patient is suffering with what is called Myxedema coma. Right. This patient is suffering with what is called Myxedema coma. What is Myxedema coma? Myxedema coma. What is the answer first of all? First option. I will explain you why first option is the answer. Okay. Now, what is Myxedema coma? Myxedema coma, it is an extreme form of the hypothyroidism. Right? It is an extreme form of hypothyroidism. All right. Now, in this Myxedema coma, remember these individuals, they will have very severe hypothermia. Right, these individuals, they will have very severe hypothermia. So whenever there is very severe hypothermia, you should do rewarming. Right, you should do rewarming. But rewarming should be done when the temperature of the individual is less than 30 degrees centigrade. Right, when the temperature of the individual is less than 30 degrees centigrade, that is the point when you need to do rewarming. That is the point when you need to do rewarming. Right, temperature of the individual less than 30 degrees centigrade. But what is the option given to you? External rewarming is a critical feature of the therapy in patients with temperature less than 34. No, that is a wrong statement. Less than 30 degrees, you need to do rewarming. And in Myxedema coma, you will have very severe hypotension. Right? You will also have hypoglycemia. Right? And the individual will have decreased level of consciousness. And they will also have hyponatremia. Right? So when there is hyponatremia, right? When there is hyponatremia, hypotonic solutions, they should be avoided. That's a correct statement. That's a correct statement. Right? What you should give? Hypertonic solutions should be given. What is the question asked? The question asked is except. The question asked is which is a wrong statement. The question asked is which is a wrong statement. Right? Next. Now in this patient with the Myxedema coma, right, in these patients with the Myxedema coma, either you should give intravenous T3 or intravenous T4. Oral formulations, they are not sufficient. Right, oral formulations, they are inadequate. Right, oral absorption does not occur in case of patients with the Myxedema coma. And in patients with the myxedema coma, the patients, they are drowsy. Already they are very drowsy. They have decreased level of consciousness. So sedation, they should be avoided. Right? Sedation, it should be avoided. Please don't give sedation. Already the patient is in a state of myxedema coma. All right. Next. Now the other point is, now this particular myxedema coma, right, this particular myxedema coma, what you need to understand and what you need to know is that it is more common in elderly individuals. Okay, and this myxedema coma occurs in acute illness like MI. Right, in acute illness like MI, myocardial infarction. Okay, or it can occur in a state of very severe infection or sepsis. Right, in a state of very severe infection or sepsis. Okay, so the answer to this particular question here is the wrong. The question asked is except. External warming is a critical feature of therapy in patient with temperature less than 34 degrees is a wrong statement. So external warming should be done whenever the temperature is less than 30 degrees centigrade, not less than 34 degrees centigrade. Okay, so with this, I will wind up the today's session. Right, I hope I have discussed a very important clinical based questions. Right. So yes, were you able to follow the questions? And how do you feel the strength of the questions, the quality of the questions? Are they very easy? Are they like medium? Are they very tough? Right? How do you feel is the quality of the questions? Your feedback definitely is very important for me to continue with further sessions as well. Right, very good. So thank you very much. With this, I'll wind up the today's session. Tomorrow, now, yes, Shravan Chaudhary, what did I tell you? Sedation should be avoided. Please don't sedate. Right, the option is sedation should be avoided. That's a true statement. Don't sedate, I'm telling you. Okay, we should not sedate the patient. Okay, right. So with this, I will wind up the today's session, and tomorrow, more or less the similar time, we will reassemble and then discuss some more clinical based questions in cardiology. Right. So the tomorrow's session will be on cardiology. Okay. Thank you very much and see you tomorrow again. Good night and stay safe.